Hello and welcome to EULAR TV. We are here at the EULAR 2025 Congress in Barcelona. I'm Maria Sokolova from the University Hospital Schleswig-Holstein in Kiel, Germany. And today I'm having with me Professor Jürgen Rech, who is a professor at the University Hospital in Erlangen, Germany. Thank you very much for being here with us.
Thank you very much, Maria, for inviting me to discuss that with you.
Yeah, my pleasure. So today you're taking part in a debate, actually, which is at the session "Individuals at High Risk for Rheumatoid Arthritis: A New Treatment Frontier?" Are you excited for that?
Absolutely. When I got the invitation from EULAR by mail, I just said, wow, invited by EULAR. What a pleasure. I'm so proud about that. And I directly accepted. Later on, I reflected what I have signed, and then I noticed that it is a debate,
Yeah.
which is not always that easy. And the debate is with Annette van der Helm van der Merwe. So I really got nervous at that time point. But I'm really happy to be here and have the pleasure to discuss that.
Yeah, it will sure be exciting. And since you're on the pro side of the debate, I wanted to ask you, in your view, what is the best evidence we have that supports actually treatment before the disease onset?
Yeah. Thank you for that question. First, I want to thank Annette that she took over the bad side of the discussion, which I think it's much easier to be pro in this setting because we have a lot of informations about why we should treat them quite early. We are not talking about if treating early means that everyone could do that or it is possible in every country, for instance, but we should figure out which patients are definitely need an early treatment. And this is one of the recommendations from EULAR. We should hit hard and early as few as possible. And that's quite important. We should treat these patients before joint damage happens. And it depends on how we use imaging in these patients. If you just use X-ray, you will never detect any erosions at this early time point, for instance. But if you look into these patients with HRPQCT, you can fix patients with ACPA positivity, that they have bony changes, they have bone loss. And if you do not treat them, they will get erosions in between 1 year.
Yeah.
And so actually there was a paper coming out last month, I think, EULAR ACR risk stratification. So with that, we know also that it's just a minor population of high-risk patients, but it is important to use imaging like MRI in this population, because then we can enrich those who are really knocking at the door of the disease, and these patients should definitely be treated. We now have 4 excellent studies, I think. It's a treat earlier from Annette itself.
Yeah.
She treated these patients with methotrexate. And what she could show was that the patients improve in quality of life, for instance, and that she could spare in ACPA negative patients money with treating them with methotrexate.
Yeah.
And if you look on working ability, you also could spare money with methotrexate in this group of patients. We have the APIPRA study from Andy Cope and his group. They treated at-risk patients with abatacept for 12 months. And what they have shown now is that they have definitely a delay of the disease onset.
Yeah.
And this is up to 4 years. And looking on a subgroup of them with more than 5 AMPA antibodies, they know that these patients are at really high risk to develop RA, and that these patients respond better to abatacept than the others. So this is also important. And they did that with the ALTO study, with the long-term observation. And now also our study, the ARIA study, we treated them with 6 months of abatacept. And we could show right now, and this will be presented in a couple of minutes by Cora Tassila, that we can delay the onset of disease by using imaging with MRI to up to 5 years right now. So that's, I think, a good situation where we're in. but we should figure out which patients are really at high risk, and these patients should be treated.
Yeah, exactly. So following up on that, do you think there is a way to improve inclusion criteria for these studies
Definitely.
or study designs so we get even better results in the future?
Yes. Looking on each result on each compound we do have for RA patients, we still stick on ACR 20, 50, and 70 in the same range. There was no changes on that. So we could change it if we try to reach this patient earlier with a treatment, for instance. We should include imaging, but the right imaging. And this is definitely not X-ray.
Yeah.
If that would be included, we have an enrichment from clinical science and lab results from 1.6% in the high-risk group up to 4.6. So this could help to enrich this population, and this should be done.
Yeah, amazing. So this field is really exciting, and I was wondering, in your opinion, do you think we should continue with the old drugs, or should we involve pharmaceuticals more to develop new drugs for this very, very early stage?
I think actually we do have a huge armamentarium of treatment options, but we use it in the old-fashioned way. Study protocols which have developed 20 years ago, something like that. There's new things on that. And so we should look in more detail how we can use them better. And we have new compounds or mode of actions which are on the way, I think, looking on SLE like T-cell engagers. They will be used also in difficult to treat RA patients now. We have CAR T-cell. Maybe we can convert these autoantibodies to be negative afterwards. And this is just a promising situation, I think.
Yeah, that sounds really exciting. And what are you most excited about for the future of this field, you personally?
I think if we have such a congress like EULAR, this is always helpful because it's not the discussion only in the sessions, but the networking outside.
Yeah.
We get more information. We should use them. We should collaborate with others. And that's to help really to improve the whole situation for the patients. And we should also include the patients to ask them what they think when they want to get treated later on when it's difficult to treat or at the earlier stage.
Yeah.
And this can move the field forward, I think.
Exactly. Thank you very much. It was a
Welcome.
very interesting interview.
Thanks so much.
Thank you all for watching, and please stay tuned to EULAR TV and have a nice congress.